So now moving on to the posterior segment, manifestations of closed globe injury. So patient with blunt trauma may look innocuous in the first look. So what we need is a careful and detailed history taking as well as fundus examination necessary to rule out the collateral damage. So like this is a patient which looks very innocuous with a subconj hemorrhage, but the first thing we have to do is rule out any occult globe injury. So what we find when we dilate the patient, there's an intraocular foreign body that has gone inside. So now the management changes and now we have to go for a vitrectomy with intraocular foreign body removal. So what happens to an eye when it receives a blunt trauma? The maximum damage occurs at the point where the blow is received. Then a compression wave force is transmitted through the intraocular fluid in that direction, causing contracoup damage. After striking the outer coats, it is reflected towards the posterior pole, and then finally it will rebound anteriorly. So all these forces will cause their own damage. So coming on to the epidemiology, the rate of retinal involvement among eyes with closed globe injury is 34%, while the rate of vitreous involvement is 22%. So posterior segment manifestations will be vitreous hemorrhage, lens dislocation, vitreous base avulsion, optic nerve head avulsion, traumatic optic neuropathy, Berlin's edema, macular hole, choroidal rupture, RPE tear, subretinal hemorrhage, chororetinitis scleropetra, retinal tears, and retinal detachment. So first is the vitreous hemorrhage, which is caused due to damage or to blood vessels of iris, ciliary body, retina, choroid. It can range from little to total vitreous hemorrhage. It may be associated with retinal breaks or it can be associated with Terson syndrome. So management is you have to screen periphery for the presence of retinal breaks and you should follow the patient until you see 360 degree of aura. We can perform a serial B-scan ultrasound if there is no fundus view to rule out retinal detachment, optic nerve head avulsion, and vitreous incarceration. The patients with vitreous hemorrhage can be observed for spontaneous resolution for 4 to 8 weeks, after which we'll have to go for surgery. So what are the indications for early vitrectomy? If the patient vitreous hemorrhage is associated with retinal detachment or a large retinal tear, non-resolving vitreous hemorrhage, ghost cell glaucoma, single-eyed patient, bilateral vitreous hemorrhage, or if there is subretinal hemorrhage. Second is the lens dislocation, which can happen with its capsule. The management is simple. You have to go for a pars-plana vitrectomy and lensectomy. SFIL can be done in the same sitting or different sitting. Vitreous-based avulsion. What you see is a bucket handle sign, that is a part of vitreous drape is over the peripheral retina, what we can see in the inferior nasal part of the eye. The symptoms are minimal. It does not cause RD per se, but the clinician has to look for retinal dialysis, GRT, and angle recession glaucoma. It does not require any intervention, but you have to closely follow the patient. Then optic nerve head avulsion, the rupture of optic nerve head at disc margin without damage to the optic sheet. The postulated mechanisms are direct trauma to the globe, sudden marked IOP rise, which can force the nerve out of the scleral canal, shearing force from the acute globe rotation. It can be either complete or partial. Incomplete, you will see a blind eye with a fixed and dilated pupil. This is the case of optic nerve head avulsion. On the left side is the early sign, and on the right side is the late presentation. B-scan, ultrasound, CT, and MRI only partially successful. It can also lead to vascular occlusion. Most common are the CRO. Then coming on to the Berlin's edema or commotio retinae, it is a self-limited transient whitening at the level of deep sensory retina. 9.4% accounts for 9.4% of post-traumatic fundus changes. It is actually a misnomer because there is no actual edema. It is caused by disruption of photoreceptor outer segments. It may take hours to develop and there is no proven treatment. It can be of two types, the milder version, that is the concussion, and the severe version, that is the contusion. The initial vision will be obviously worse in the severe version, which will be associated with more intense retinal whitening and retinal hemorrhages. Recovery is usually complete in retinal concussion, while retinal contusion will leave some pigmented scars and visual recovery is not complete. If you do an FFA, there will be no findings in concussion, while in contusion there will be intense staining or a leakage. This is the late photo of contusion. Always remember to record the baseline visual acuity for both eyes, to document presence or absence of RAPD, to examine other eyes for the presence of signs of trauma or pre-existing disease. Normal interior segment vision should not deter the clinician from performing dilated retinal examination. Thank you. I thank Chitranjan sir for providing